is Erin Hoban from Medicaid. I'm on the phone.
I'm sorry, I couldn't hear you again. Who was it?
Sure. This is Erin Hoban with Medicaid.
Got it. Thank you, Erin.
Steve from Madisonville.
Oh, Steve, great. Thank you.
Dale Wilcox with Communicare.
Great. Thank you, Dale.
You got something you can send me.
This is Jen Rushman and Nick Kostoff with Cincinnati Children's.
Oh, great. Hey, guys.
Hi.
Okay, send it to me. Send it to me. Okay.
Now, Jennifer, who do you have with you?
Nick Kostoff. He is
that's
one
Nick.
of our
Okay,
IS.
Yeah, I put him in my contact list, but we just haven't met before. So. But you know I can fix that.
You cannot escape.
Anybody else on the network we haven't checked in with yet?
Oh. Well, I usually try to avoid that.
I'm crashing.
Guys, we'll do a final roll call in just 1 or 2 minutes, and we'll get started. As soon as everybody gets themselves settled in, get your tent card so you're official. All right, guys. In order to be timely, we'll go ahead and get started. It's 11:01. I thought there was somebody. Donna said she was going to have somebody come to take notes. I hope that doesn't fall on me. Or somebody was going to record it. But I don't see anybody ever record it. That's right. Yeah, no.
That'll be difficult, but I'll try.
I can record it.
There you go.
Oh, you know what? I can have my office.
We should be able to tell these guys to record it.
Yeah, Robert Bell, I know that you're connected. Can you still hear me?
Yes, sir.
Robert, would you be able to throw this into a recording?
It's being recorded.
Oh, it is being recorded. Oh, well, then you're way ahead of me. Thank you, sir.
You're welcome. Have a good day.
Okay. Guys, before we do a go around the horn introduction, most of you guys probably know this, but some of you don't. And for those of you that haven't met her, there's a bunch of us that work on this all the time, but frankly, without Donna Vino, nothing happens. And Donna is the administrator to the board, so frankly, she does all the work. Donna's mom passed away last week, and so she actually will be at the funeral in about 2 hours, I think. So if you would just keep Donna in your prayers. I know this has been a long time in coming, and frankly, Donna and I have had a lot of talks about her faith and my faith and her mom's faith, and we know that everybody's secure in their faith, and so it is, well, it's not a happy time for anybody. They're as ready for this as they could be. So please keep Donna and her family in your prayers. If we could, I just want to go around one more time and make sure everybody introduces themselves. Shoot, let's just start in this. Yeah, why don't you?
You guys come up to the table.
Yeah, you could join us.
David, John. Come on up to the table.
Shy.
Okay. So if we could, maybe we can just start. We'll start in Frankfurt and just go around the table. Just let everybody introduce themselves. If you guys want to start on that side and work your way around.
Oh,
Just say hi.
sorry, Marie Cole, Cohenhagen.
Connie White, Department of Public Health.
You're up next, Doc.
John Langfeld, Medicaid.
David Bowl, Kentucky Primary Care Association.
I'm Rob Sprang at UK.
Rodney Murphy, Office of Administrative Services for the county.
And Russ Bissett, member of our
Paula Mullins Bentley from Kentucky Health Information Exchange.
Jim Barnhart, Commonwealth Office of Technology.
And I'm Jeff Sutherland from Medicaid.
I'm Dana Nicholas, I work in the Secretary's Office at CHS.
We can catch up with you two. Just kind of.
Good morning, Stephanie Mayfield, Public Health Commissioner.
Bill Hackrat choked her up.
She's so happy to see you.
And let's go over to Baptist Madisonville.
Good morning, Steve Fricker, Baptist Health, Madisonville.
Hi, Steve. Thanks. And we have a representative on the phone, I believe, from Medicaid. Aaron, do you want to introduce yourself one more time with everybody here? All right. Dale, you want to, again, we're recording this, so everybody, we want to get a record of everybody who's at the meeting.
Yes, Dale Wilcox, Communicare.
Calvin Jackson, Communicare.
Great, thank you guys. And Cincinnati Children's Hospital.
Hi, Jennifer Rushman with Cincinnati Children's.
Nick Kostoff, Cincinnati Children's.
You guys didn't know we annexed Cincinnati.
No.
Just brought them into northern Kentucky.
Suburb of Covington, right?
That's right. University of Louisville.
I'm Tim Bickle, the telehealth director at U of L.
Bob Esterhay, University of Louisville School of Public Health and Information Sciences.
Ken Gardner, director of technology at the School of Medicine.
I'm Dan Kogan, Assistant Dean for Continuing Medical Education and Professional Development, School of Medicine.
Great, thank you guys. And St. Clair Regional Medical Center.
Good morning, I'm Mary Horsley and I'm with St. Clair and Moorhead.
And is there anybody else on the network that we haven't caught up with you in kind of this formal introduction? Because we want to make sure we get everybody listed for the recording. Aaron, you out there? Okay. And actually, Sherry, we're recording this. We don't have a secretary today, so if you could just introduce yourselves. Oh, we have more coming.
Sherry Rose, Commonwealth Leverage.
Dr. Payne, you're the last one in. If you could just introduce yourself. We're capturing everything on recording.
Good morning, Vaughn Payne from Humanitarian Source.
Great, thank you.
And Brian Yawkey will get in here shortly from Student Journal.
Oh, okay. Oh, wonderful. Okay, good. All right, guys. For everybody on the, pardon? I think we did.
What is the required quorum? We have 6 and we got 2 and that's on this.
Yeah, I think. Don't we have 5?
We've got a majority.
Yeah.
I hope we have
Yeah. And everybody on the network, did you get Donna's distribution with copies of all the paperwork that we're going over today? Or anybody that didn't get it, please speak up. All right. I mean, I got to tell you guys, Donna put all this stuff together over the weekend and brought it in yesterday and set this up. So, I mean, she really went above and beyond. So, for the record, Donna, thank you. I don't know if, I hope you guys had a chance to look at the meetings from last month. What I can tell you is that the training center directors did go through them. They are pretty lengthy, but has anybody had a chance to go through them and make any, you see anything that needs to be changed? All right, I will assume that everybody is good with them. Could I have a motion to approve the June minutes?
Motion to accept the minutes.
All right. Could I have a second, please?
Second.
All right. Any discussion on the June minutes before we go to a vote? All right. All in favor of approving the June minutes, please respond by saying aye.
Aye.
All opposed, nay? All right. Thank you, guys. June minutes are approved. First order of business, and I think most of you guys probably have a document, or may have a document that lists the people that are requesting membership to the board. We've got several. Actually, David Bailey, did you join by phone online? I know David was going to try to join today. The first one that we're going to consider is St. Elizabeth Healthcare in Covington. David was hoping to participate in the meeting by telephone. They are requesting KTHN membership for the facilities in Edgewood, Florence, Fort Thomas, Covington, and Williamstown. They are about a 2-year grantee for the Foundation of Healthy Kentucky, working with North Key Comp Care Center, I believe it's North Key in the region, to bring mental behavioral health support into the emergency rooms. And so what they have done for the last 2 years since they had the grant is that they're delivering the service. They just never really thought about billing for the service. And we actually met with David and said, well, David, if it's going to be a sustainable project, you probably need to be billing for this, which is, in their case, is very appropriate. They have technology in place for the last couple of years. It is H.323 compliant. We will need to test with it, but it will be very, very simple. And so what we would do today is offer up provisional approval subject to testing of the technology in the next week or two. Anybody got thoughts or comments? Or David, if you happen to be out there, just unmute your telephone, you can speak up.
Question on the actual foundation.
Yes, sir.
Does it include the hospital?
The grant was actually funded 2 years ago before they had to work with Owens. Oh, good point. They didn't include Owenston in the application. Do you know if they put equipment in Owenston yet? They did. All right. I'm going to take some liberties, if that's the case, because Owenston would be as good a place that it's more isolated than even any of these that they have listed. I'd like to provisionally add Owenston to the list of requesting membership so that they don't have to come back in 4 months and they can go ahead and begin to move forward with this. I've talked to David a bit about this, and they're really anxious to do this. So does anybody on the board have a problem or a concern with us adding Owenston to the request?
I move to approve provisional approval with confirmation that Owenston is included.
Very good.
That covers.
Yes, sir. Do I have a second?
Second.
Wonderful. Any discussion before we go to a vote? All right. All in favor of approving St. Elizabeth Healthcare's request to join KTHN with the addition of Owenston provisionally, subject to testing of the technology, please respond by saying aye.
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 And all opposed say nay. Somebody just joined us at a circular white table. I'm sorry, my guess is that was probably you. All right. Okay. I'm assuming that was not a nay. So motion passes. Thank you guys very much. We'll alert St. Elizabeth Healthcare. Oh, somebody just said in there. Somebody just, yeah, we've actually had a couple places just connect. All right, guys, so St. Elizabeth Healthcare is approved. Thank you. The next,
Bob, we don't have a list in our handout.
oh, you don't have a list of the sites?
No.
Oh, I'm sorry, okay. I thought Donna had sent it. Okay, I'll make sure to read them all.
How many do you have to go?
We have Cardinal Hill, Cincinnati Children's, Manchester, and Our Care.
Oh, keep going.
Yes, sir. Thank you. Cardinal Hill Rehabilitation Hospital in Lexington. They would like to use telehealth for specialty services to consult with patients to avoid disrupting services in the hospital, specifically not to have to move rehab patients out of the hospital and send them back to the emergency department, especially those post-surgical patients. They're going to be really difficult to transfer. I realize they're in Lexington, very close to other hospitals, but it's a real burden for them. We did a little bit of research, and this happens way more than you would imagine. They do have H.323 compliant technology. We have already done testing with them. So their approval, or their request for approval, is for full approval just for Cardinal Hill Rehabilitation Hospital. So could I have a motion to accept Cardinal Hill Rehab Hospital?
Move to accept,
All right. We have a motion to accept. Do we have a second? All right, we have a second. Any discussion before we move to a vote?
Rob, this is
Yes,
Tim.
sir.
I'm just curious, are these, is this consultations within the facility?
Yes.
Or is
Oh,
this-
no. No, this would be from Cardinal Hill Hospital to it would be the patients would be in Cardinal Hill, rehab patients in Cardinal Hill to medical specialists outside of Cardinal Hill.
Outside of Cardinal Hill?
Yes, sir.
Okay. So the outside specialists, though, would they need to be Medicaid
If it's
specialists?
Medicaid, absolutely, yes. And so I think the assumption is that they would be referring to places, I mean, almost exclusively, I think, in Lexington, it will be Baptist Lexington, St. Joseph Lexington, and UK within the city.
Okay, so those are not, they wouldn't qualify for Medicare.
That's correct.
Reimbursement. Okay.
That's correct.
That's,
And just for anybody that doesn't know, Medicare does not reimburse when the patient is in a urban community. That Medicare does have a rurality limitation. Okay. Any other further discussion before we go to a vote regarding Cardinal Hill? Okay. All in favor of approving Cardinal Hill Rehabilitation Hospital for full approval, please respond by saying aye.
Aye.
Great. All opposed, nay. Motion passed. Thank you guys very much. Okay, we do have a representative from Cincinnati Children's Hospital. Jennifer will be participating in the meeting, and they're actually on by video conferencing. They're requesting KTHM membership for their medical center in Cincinnati and children's outpatient facility in Crestview Hills to provide pediatric subspecialty services by telehealth. They do have H.323 compliant technology. We will need to test with the outpatient facility, but as you guys can see, they're able to connect to us today. And so they're requesting provisional approval subject to testing of the technology as requested. Do we have any discussion? Jennifer, anything you guys want to say before we get move on toward the vote? Oh, you're muted, Jennifer. I think. Okay.
Do they
Jennifer,
need a Kentucky license to do that?
yes, absolutely. The point of service is where the patient is located. And so they do have to have a Kentucky license. I see Jennifer nodding because they're well aware of this. Mary, would you do me a favor? Mary Horsley, could you call Hayda at my office and just make sure that they have not muted people that are coming through from us? Jennifer, I'm sorry, I don't know what's going on, but we cannot hear you.
Sure, can you hear me?
Yes, ma'am, just fine, thanks.
Okay.
Jennifer, is it possible your mic is still turned off? I'm sorry. Okay. And then, Mary, if you do call Hayda, ask her to call the folks at COT as well, and just make sure that Cincinnati Children's didn't accidentally get muted on the bridge. Thank you, guys.
Rob, also Erin on the phone said that she can't hear either. So I don't know if it's her phone or it's I told her I was
Okay. Do you have a way to talk to Erin, or just to get a message to her?
Yeah.
Ask Erin to call 859-257-6404. Ask Hayda, Hayda, to give you the phone number to call in here. Great. Okay. Jennifer, I'm sorry, but I think we get the gist of your request. If I'm missing anything, wave your hand frantically, and maybe we can figure it out. Okay, any other discussion regarding Cincinnati Children's Hospital? Okay. All in favor of approving Cincinnati Children's Hospital Medical Center as well as the outpatient facility in Crestview Hills? Oh, I'm sorry. We need Thank you. You didn't kick me under the table. Thank you. I need a motion to approve Cincinnati. Thank you. And do we have a second?
Second.
All right. Any final discussion before we go to a vote regarding Cincinnati Children's? All right. All in favor of approving Cincinnati Children's Medical Center as well as the outpatient facility in Crestview Hills for provisional approval subject to testing, please respond by saying aye.
Aye.
Question.
Yes, sir.
They were already tested out there.
Cincinnati Children's definitely is the Crestview Hospital, or Crestview outpatient. It's not. So yes, we'll test that, but yes, we do know that they can work. All right, and all opposed, please say nay. Very good. Motion approved. Thank you, everybody. All right, next up, Manchester Memorial Hospital. Jamie, do we have Jamie Couch online yet? Jamie was going to try to connect. They are, Manchester is an approved site, but they are now asking for Owsley County High School, Owsley County Elementary, Manchester ER, which is really part of the hospital, is already approved, and the Manchester Surgery Center and the Glendale Medical Care to bring telehealth services to schools and psychiatric and other specialty consults to the schools. We have tested with Manchester Memorial Hospital. You like that idea?
That is great.
There we go. We already have Manchester Hospital as a member. These will receive provisional approval because they do not have their equipment yet. So when they get their equipment and install their equipment, then we will test them and move that from provisional approval to full approval. Since we don't have Manchester here, anybody got questions or comments about the Manchester approval?
I just want to comment, I think this is great.
No, we started doing school health in '97, but it just sputtered. It was really tough. David knows as well as anybody. He started the program.
Owsley County probably is the only one or two counties that has no physician in the county. Robinson County, I think, is the other.
It would probably be nice for us to almost have a monthly report on how we're doing down there, just so we can keep up with this and help encourage and support it. So, but I think it's great.
Yeah. All right.
Move to approve.
All right.
Second.
All right. All in favor of approving the Manchester Memorial sites to the network, please respond by saying aye.
Aye.
All opposed, say nay. All right. Thank you guys very much. The final request that we have is our care coming out of Augusta, Arkansas. Greg Wolverton is representing ARCare. They're asking for KTHM membership for the facilities in Bardwell, Paducah, in order to deliver school-based services. We've talked to Greg several times about this, but this is, they're really committed to coming to, Greg, we have you, this one we had him. Greg, we happen to have you on the phone? Okay. They do not have they do not have equipment in place, but they do have a contract to deliver school health, and they want to do that, supplement that with telehealth. So, anybody have any questions regarding that application?
What counties are they going into?
At this moment, it is just, they're going to, I think, 4 schools in Paducah.
Okay, thank you.
That, I believe that's the one, the first step of the project. They don't have the equipment yet, so we've not tested with them. Any other questions about the project? All right. I need a motion to approve the ARCare request.
Motion to approve.
You got a second? Any further discussion before we vote? All right. All in favor of provisional approval for the ARCare sites in Paducah, please respond by saying aye.
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 And all opposed say nay. All right, guys, approved. Thank you very much. A bunch of new sites approved this month. Thank you guys very much. Before we move on to really what Don had referred to this as an open forum, I wanted to make everybody here and make you guys aware that we'll be getting more details about this going out to everybody soon. There are 2 really interesting conferences that are going to be coming up in the next 6 months or so. For all of you that are even on the periphery of telehealth, the term direct-to-consumer is a hot topic right now, and certainly within the world of accountable care, we are going to have to respond to that direct-to-consumer telehealth ideas. And there's now, what you find is that, and I will not drop the name of this national company, but there is a national company that has been cited in at least 2 states already for doing some telephone care that they've probably overstepped their bounds. And so there's going to be a conference in Washington, D.C. I want to say it's November 14th and 15th. Anybody interested, I'd be glad to get you information about it. But there are some real big players that are coming to this, and it should be really interesting because it's one of those things that there's just, everybody talks about doing it, but nobody talks about really how to do it, and there's some people who are doing it incredibly successfully. But there's also some people that are really pushing the envelope, maybe unnecessarily. And what it's doing is bringing some focus from the Federation of State Medical Boards and CDC and the AMA and others. And so this is going to focus on how do you do it well, and how do we make sure that these programs are able to succeed. So interesting program in December, and at the end of March.
I'm sorry, Rob, that's November 14th and 15th?
Well, it's a Thursday, Friday, so it's that week, maybe it's 13th, 14th, I forgot, but yes.
Who's sponsoring that one?
Center for Telemedicine and eHealth Law.
Okay.
And I've got some information on a brochure that they put out for it. The other meeting, which is a much broader program, and I think it would be interesting to almost anybody that has any kind of interest in telehealth, is that the Mid-Atlantic Telehealth Resource Center is going to hold their annual conference. And Dr. White knows about it, and anyone else? Maybe just 2 of us were there. But every year they have oh yeah, of course, we have people online, and Sam was there. But every year the Mid-Atlantic Telehealth Resource Center, which is a HRSA-funded, one of 14 national or regional resource centers all over the country, hold a summit every year. And this year's summit is going to be telehealth in a reformed healthcare environment. So really talking about, as we move from a volume to a value-based healthcare system, where's the role for telehealth? And I think those are questions we're all asking right now. That will be the end of March. And the good news is it's at the Greenbrier in West Virginia. And even better news is that the daily rate is $109. I don't know how they pulled that one off. So we are working really hard for everybody to stretch this a little bit. And, yeah. You get a twin bed with staff. Yeah, you have to cook. I forgot. You had to cook the meal. Yeah, but I mean, I don't know how they did it. Maybe it's a little early in the season, but I mean, I can't afford to go that twice. But so it'll be it'll be a great conference. It's always a good conference. But it's an opportunity to go to Greenbrier. So you put that on your calendar. We will put something out to the listserv very soon. But if it's something you guys are interested in, just shoot me an email, and I'll get you kind of a draft of what the agenda is going to be. But
just have Donna send it out.
Yeah. Oh, good. Okay. Good point. Yeah, Donna will hear that on. Yeah. I mean, who cares what the agenda is? It's a Greenbrier. Well, that's what we plan. So, all right. So keep those two conferences in mind. Really, for the rest of the day today, Donna had kind of drafted out for us just an open forum, and I need to stop talking and have you guys get to talk. But the concept is just the future of telemedicine in Kentucky. And we all know, anybody that was at the last board meeting or has been paying attention at all with us lately, that the resource centers in the state, that since the original passage of the legislation in 2000, have received some funding from the state have gone away. And so now we have essentially an unfunded mandate of 4 telehealth resource centers in the state. And the question is, way above and beyond the resource centers themselves, what should we do? Should we have a central body that kind of manages or at least watches what goes on with telehealth in the state? Or do we need to have kind of a wide open, do your thing? Everybody, it would certainly, if we did, it would certainly open things up for innovation, because there are some criteria that the board has, a membership with the board, to bill for Medicaid, and the Medicaid billing doesn't change if the reg doesn't change. So even without a governance board, you're not going to add new sites to be approved for Medicaid. So I'm going to turn this over to the group. I think Donna gave us some maybe talking points that we addressed. Should there be a cohesive governance structure? The current board membership is 10 members. We may want to consider expansion, and I think that Donna has drafted, I think everybody has a document with a blue banner across the top, Kentucky Telehealth Board Membership. And so on the left side is the current board membership. On the right side would require legislative change to expand that membership. So I'd like you guys to think about that. She has other points. Should the law remain to require membership in KPHN to be eligible for Medicaid reimbursement? Is there any value to the resource centers? Is there any value to the statewide online telehealth network schedule? Because that will no longer be funded as well. So I'd like to open it up to the group and just hear what you guys have to say.
I had a question, Rob. There was a letter that was sent from the board last meeting, and I wonder what was the response on that. Was there any? I think it was a shortfall, as I recall from memory, about $300,000 a year. Is that correct?
That's correct. And I think that, and I hate the phrase, but it is what it is. In the state government, there's just not any money right now. So that I think our shortfall, our allocation allocation was $265,000. That included some funding for each resource center. It also funded some of Donna's support for us. As I understand, Donna is going to continue to be supported enough to help this body, this board continue, which is, again, we can't live without Donna doing that. But I think the net is there's not a response right now.
Okay.
Yes, sir.
What's the value of this board to the leadership of the administration? Do they want us to continue? What's their vision? I can ask that question if you can.
Could you all speak up just a little bit, please?
Sure, Tim. The question was, okay. Tim, the question was, how does the state's leadership value the board? I think it's a great point, and I think we should network around more broadly to understand that. I mean, my contact has been in a couple meetings with the secretary, and I understand that I guess you vote, maybe you vote with your money, but in her case, she's always been an incredible supporter of telehealth. I mean, she really believes in this, and I think to some extent we all share, and I think the state shares the vision that you can't do reformed health care without telehealth. But there is no money right now for it. Look, we have some leaders in the room. If you guys any thoughts? I mean, you sit in much higher level meetings than any of us do.
Hey, Rob, this is Kent Gardner at U of L.
Yes, sir.
I think you kind of already made the point that in this time of tight budgets, I don't see how we can afford to cut $250,000 that ultimately saves many times that in Medicaid dollars. These people that are being seen through the telehealth system are going to there's going to be greater expenditures to transport these people to places to be seen, and it doesn't take many visits to pay for the amount of money we're talking about here. And I think there's an assumption that telehealth will just magically go on without the support. And while it is a small number, if we lose positions right now the university is trying to figure out how do we afford to keep a Tim Bickle. Without Tim, I'll guarantee you, telehealth around here would dry up almost overnight because somebody has got to administrate it. So for a very small expenditure on the state's behalf, there's a great deal of savings taking place here. And it's really not, I don't even see this as money is tight, so it has to be cut. It's one of those things that money is tight, we should probably expand this program.
I think it's pretty clear, and we have the cabinet represented with the Secretary's Chief of Staff and the Office of Administration and Financial Management from the Secretary's office. It's pretty clear that we want public health, and that with all the people that fortunately have been added to our Medicaid rosters now, that we know that it's going to be a tool for workforce. So I think we're in agreement. So when we think about, in my mind, when I think about the board, how do you see the board evolving now? And then we can go from there. But what do you all see a board doing in this day and age? Because you've got a lot of big players out there using telehealth. Our major institutions are using it. What is their role now, and how would they use a board? What do we need the board for now?
And I think we should pick that up, David. Did you have a?
I think it's even more fundamental than that. If you look at the state statute under KRS 216B, it grants the cabinet the ability to.
I'm sorry again to interrupt, but do you all have more microphones available in that room?
No, I apologize.
Read my lips, Tim.
I'm sorry.
I'll try to speak up. It's not just an area of innovation but it's an area that probably needs considerable control for at least some period of time. And I think that's an appropriate role in what was envisioned in the original legislation. Now, from a practical standpoint, if I'm sitting in Vanceburg, Kentucky, and I want to do telemedicine, and I have to do it on 3 different platforms to reach 3 different organizations for services that we need in a rural area to maintain the health and reduce the cost of care, then it puts me out of the market of being able to do that in that small, rural primary care clinic. So a standards-based approach is ultimately, I think, the best way to go. That doesn't limit innovation. Another great fear I've got is that if this is not in some way regulated to benefit the public safety, that we could cause more problems with pill pipelines than we had when Florida was still in business. So frankly, I think it's a matter of public safety, and I think the board should function in that light with an eye toward how can we be more innovative. You know, the first room I saw set up cost over $500,000. Now you can set up a room for about $2,000 and actually do telemedicine. And there will certainly be more changes that come along. But again, if I'm sitting in a rural area and I'm working with, if U of L's on one system, Cincinnati's on another system, and UK's on another one, I've got to be able to talk to all of them. And I think that's where the board and its technical expertise supplies some information. I also know, or some guidance. I also know that we've got a lot of folks now realizing that this is a technology that we need that can be useful in improving the health of the populations they serve. And actually, the technical assistance side of it is probably going to be more important than it's been in the past. The change in the regulation allowing primary care to bill for the services, I think will help that. So you open it up, but you regulate it so that it's appropriate. There's a standard of care and a standard of operation, and that to me is the board's responsibility.
Tim, is the audio better to you? The state should have bumped.
Right, they pumped it up. We had it pumped up so much here that our static was louder than your all's voices.
Yeah.
Okay. Yeah, we're much better now. Thank you.
Okay, great. Thanks, guys. David and Dr. Mayfield, I think they bring. There's a couple points I just. And again, maybe it's not semantic. I think it's important for people to understand. We're talking about the board, and we're also talking about the resource centers. The board, the intent certainly is the board to keep going on with Donna's support, and you guys don't get paid to come to board meetings anyway. So I think the expectation is that you'll keep coming to board meetings. The resource centers were funded, and they were funded to help others. Dr. Mayfield sat in the K-High breakout sessions with the training or with resource center directors, and it was 2.5 or 3 hours of, well, I want to do telehealth. How do I do it? And it was that very basic, kind of prepping people and telling them, you can come to see us. We will go to see you. All 4 of us will help people that don't necessarily come back to benefit us in any way. We cannot do that without external funding. Now, whomever is interested in telehealth in the state will they'll have to go find help. Maybe they go hire a consulting firm. But we just won't be able to fund that kind of support for people like that. So as a group, as we talk about this, I think it's important to talk about the continuation of the board, and then what Ken said in Tim's case, the continuation of the funding of the resource center, which is, again, what jeopardizes those positions now.
To that end, Rob, we just approved an Arkansas-based healthcare facility providing telehealth. And that's great. We need providers. But if we do not keep these resource centers open, you're going to see more and more of those resources coming from out of state. Now, I'm going to make a bold statement here, and some will disagree with it, and as long as you're comfortable with being wrong, you're welcome to. But over the next, in this century, the majority of patients will ultimately be seen via remote healthcare versus face-to-face healthcare. We are approaching that period. People will look back on this time and say, bringing all the immunocompromised people into one room was the bleeding of bad humors of our era. This is going to change. If all these other institutions are already on the ground and providing this health care in Kentucky, that just means all our doctors are going to leave the state to provide the telehealth. And we'll be paying tax dollars to other states. We'll be sending money outside the state of Kentucky, opposed to right now, we actually have a strong telehealth network, and we could be one of the nation's leaders in this area if we really start trying to push forward, and we need to be going in that direction. So that's a concern of mine as well.
Hey, Rob?
Yes, sir.
I'd like to make a recommendation that the people consider the board expanding into a public-private collaboration. And I don't know if Donna's and yours and Tim's and whoever else worked on efforts to try and achieve that, but if you really want to deal with the fact that the big elephant in the room is the lack of a sustainable business model, everything we talk about is cost avoidance, you're going to need the private sector involved to figure out how to create new businesses that actually generate money. And so the problem is there's no sustainable business model. It's always been the problem with telehealth. It's the problem with HIE. 75% of all the HIE installations across the nation do not have a sustainable business model. So the big pain point for the group is the fact that there is no sustainable business model. And maybe this is an opportunity to have a public-private collaboration or alliance that actually focuses on the fact that there is no sustainable business model. You can certainly make the argument for cost avoidance, and perhaps that's a way to get hospitals in the short term to help contribute to reducing hospital readmissions. It's a way to deal with transition of care problems as patients move from hospitals to nursing facilities and skilled nursing facilities and move back and forth. There is no complete information on a patient that's readily available in digital form. That's the new business opportunity. And so I would recommend that the board consider a public-private collaboration, have the membership of the board expand to move in the direction of having the private side being considered, and the focus be on a sustainable business model. And in the short term, we do the best we can to keep everything glued together. That's my comment.
I actually think that's a plan worth exploring, a public-private partnership. This is Stephanie, Public Health. I actually think that's a plan worth further exploration there, and I think that if there were board members that were more reflective of some of the practitioners out there today doing telehealth, they may be able to come up with that public-private partnership there and a sustainable model going forward.
Do we know if other states have that model right now?
A lot of the states that have, I'll do some research. We've done a little bit of research on this. I'm not. The public-private partnership is probably more aligned with states that when they first started their programs, they created a subscription model where they said, you'll pay as a site, you'll pay X number of dollars per month, per year to be a member of this, and then we will bring that money in to the core. Looking back on it, should we have done that, in '95? That would have helped us today. It'd be hard to flip that switch now, but certainly it's something we've talked about. But we can do some research.
One of the things I would say is that following up on Dr. Escay's point, is that I think if you look at the proposed membership for the future board, almost that has been accomplished because realistically, many of the suggested new members would have secondary motives that would benefit their industry. And I think, Bob's point was that eventually they would contribute financially, but as a first step, at least if they were a member of the board and they're benefiting, then I think one could put the financial tap on them.
That's what we need the board for. Yes, that would be very helpful. I think that's a great idea.
So I don't know if it's appropriate, but maybe is there, a desire to have a motion to accept the idea that's presented here for the proposed membership?
Well, because this will require legislation, and actually the state has been kind enough to say, we believe that this is kind of the direction we need to go. Have you guys had a chance to look at the previous membership and the new membership? Is there somebody that you think, and we don't want the board to be too unwieldy. There is a point where there's too many. Is there anybody on the right side that you think maybe we don't need, or anybody on the right side that you think we're missing, we really need? Like, we've reached out to you, Pike, and talked to a couple people, but really haven't heard anybody say they want somebody.
Rob?
Yes, sir.
Just to clarify and to let everyone know, we have already submitted the application for a legislative change. Now, the legislative change doesn't specify any detail, but it's the step number one you have to go through in order to submit a change of statute. So we got our foot in the door. Now we're asking the board to help us define what should the legislative change look like. I didn't know if that was maybe not clear enough.
That's a very good point. Yeah. January's coming really quickly, so.
Who makes the decision when two names are submitted?
I think that's the governor's decision.
Most of the time it's the governor. I don't know how it's stated in the news.
Because I think historically, all these requests go to the governor for final approval.
Sounds like it goes to the appointment office, I think.
Yeah, normally there's nominations that are made. It's the governor and the governor that makes the final
Rob?
decision.
Yes, sir.
Rob, having been involved with the initial legislation and helping to write it, it is the governor that appoints the entire board. And I had proposed a different structure of governance when that legislation was being written, and it became very public and not private. So this would be a recommendation in the proposal to change the makeup of the board to more represent both the public and the private sector in a more balanced way. But the governor still would be the individual who would appoint all the members of the board, and he or she would do that in consultation with the various organizational entities that are involved in this proposed board membership going from 10 to 16. My only concern about was to be sure that there were enough consumers on the board, because we're going to be moving towards consumer-directed health care one way or another, whether we like it or not. It's going to happen, particularly with our advances in communication and information technology.
Good point.
This is Rodney Murphy with the cabinet. I think most of you have been around me the last few discussions know I've been pretty passionate about this topic and speaking out probably more than I need to. But Dana, I'm going to put you on the spot. When when do we have to have a finalized legislative package for any changes like this put together? What's our calendar requirement?
Well, I mean, we are already have had to submit some documents of what we would like to see happen in this legislative session as a cabinet. So we have kind of a placeholder for telehealth, just like, you know, put folks on notice we're interested in maybe proposing some changes, but it sounds like U of L is also kind of on the same track. So I don't know when the drop deadline is. I could ask our legislative director, but I think it's soon.
Well, I think we need to know how much time we got to chew on, whatever it is we're going to try to chew on. So.
Well, and Dana, you know, again, you guys are taking the lead on helping us get this submitted, but isn't it going to be up to the board for us to go find legislative champions to introduce?
Typically, we work, as a cabinet, we work through the governor's office in selecting sponsors for legislative. You know, of course, we work on a lot of legislation that other people file. So, you know, and in that case, you know, if U of L does, obviously they'll find a sponsor if they have their own legislation. But if it ends up being cabinet legislation, then typically we work with the governor's office to get it done.
Okay. You know, because guys, as we look at the legislation itself, the original legislation that passed in 2000, save for this board membership change, was very permissive. Regulatory language is what narrowed down what we could and could not do. So I think if we're able to essentially make that change in legislation, then over time we can look at what happens from a regulatory perspective. So I guess what's next?
I just wanted to ask two questions. And folks, I'm a political nitwit, okay? So I ask a lot of dumb questions and post some things, but this is really coming from Rodney Murphy as a citizen more than anything. I think we're all on the same side here. We all believe in telehealth and believe it needs to be move forward. But it seems to me from the training center standpoint, my reflection is we had at the Digital Health Summit, we had 2 breakout sessions, and I was able to go to one of those. And in that session, any of the rest of you, Rob, I know you were there, but there were a number of folks that basically expressed an interest in starting telehealth programs, both from the provider side and the payer side. And frankly, I was a little shocked that they didn't know exactly how to get started. I mean, they expressed the fact that there was not a good resource, or they didn't know the resource to be able to get the technical expertise they needed, support to be able to get going. Which to me just had me pounding on the table saying, this is a real need for something, either the training centers that we've got, or resource centers, if we want to use that term, or to develop some mechanism to be able to do that. So, in my opinion, it would appear there's a need out there. You couple that to the gentleman's point earlier that telehealth apparently can reduce the cost of providing services. There should be folks out there in the payer and the provider community who would like to be able to have those resources under contract to be able to do that work. Since we don't have the funding we had before, I would have to think we should talk to them about the possibility of at least a near-term ability to bridge the gap on the budget that we need for these resource centers until we can formalize something that I think Bob's idea is a great idea, some sort of long-term public-private partnership with a sustainable business plan to have the necessary resources to encourage the deployment and expansion of telehealth across the state of Kentucky. The second point, though, is one that I think is going to take longer-term discussion, and I think, David, you made a couple of comments. The scope of the board right now, unless somebody tells me differently, really does not cover things like standard of practice. It really doesn't ensure, the authority of the board is not there to be able to ensure that we have good medicine being practiced on telemedicine. It's just that when you turn on this end, you can see doc on the other end. So I think a whole discussion about the scope, role of the board, which goes well beyond the funding of the resource centers, is something that this board is going to have to take up, and certainly it's going to have to be by people smarter than me. But the bottom line is the board is not right now legislated to do some of those standards of practice things that we all believe needs to be done, and that's a whole new set of legislative issues if we take that on.
Well, and to that point, I mean, just, you are way more familiar with telehealth than me. I'm just now learning about it. But in researching everything, it appears that the licensure boards currently play that role. And so I guess it would be interesting to know from the board members, is that adequate, you know, that the licensure boards do that, or does it need to be done by a telehealth board?
Or does the telehealth board need to support the licensing board and help and educate them in developing the right kind of regulatory language or whatever to do this way? I don't know.
Well, key things, again, going back to 216B cabinets authority to regulate in the interest of certain services. That's for your license culture. I think you've got. I'm not really convinced that any of the boards do that right now. But back to your point, Rodney, about boots on the ground and look at what we've had to do and to get EMRs implemented across the state. And I still have providers every week to pop up and say, "What's this EMR stuff?"
Right.
You know, and we've been preaching it for ages. Just a few of them, you know, but you know, we run into it. And again, you bring both of those things together. You look at one of the major issues that a lot of the national ACOs are having is because of lack of interoperability with various platforms and systems, so that providers can talk to them. Certainly, that's something we push forward with KHIE and the RECs and everything. So everybody's got to talk to everybody else. I mean, I like talking to everybody, other people, but that certainly does help. And again, my basic concern there is if I'm out in Vanceburg and I've got to have three different platforms, I'm not going to be able to do that. So certainly we've been through a lack of standardization before, and it's created cost and not improved quality. Another very so I don't think we want to get on that path because that's totally up to the board. It's no doubt we're going to get into this for 20 years.
Speaking from the perspective of at least my NCO, here, we would love to have focus on the environmental.
Well, to that point.
If nobody heard, he said no.
Yeah.
Anybody out there?
And at this point, he's going to say no because his first question should be what's in it for me. That's what this world is all about. Now, my question is, do we not have the ability to sit down and have a discussion? I assume it's with payers, both NCOs as well as other private payers in the state, maybe even some of our institutions, to say, in order for us to be able to enhance the use of telemedicine in the state, what services do you need to be able to get this done? And if so, can we produce a budget to provide those services that you all may be willing to fund? Just to have the conversation, just to see if we can get some dollars into the coffers. This current board has the ability to be able to take those dollars, put them in a fund, and pay training centers. It's all in statute today. But the bottom line is we need a source of dollars. If those services are critical, which we all think they are, if they're critical to the payers, let's ask them and let's find out what they need. And if we can provide that, I think we can give them a hell of a deal on it. I really do. But I'd like to be able to have the form of permission or whatever we need to be able to go forward and ask those questions.
Well, you know, we heard earlier that the government suggested that money is saved because of
what's that?
I'd like to see the pro forma, some stuff around what's the value proposition.
Exactly. I mean,
what's the value proposition when you talk about payers? Don't forget, we're not just talking about third-party payers.
many large employers are self-funded. They make decisions about their own groups. A lot of the hospital systems actually are self-funded. The state's self-funded. Those are payers. They make decisions. There are a lot of on-site clinics that can be linked, those resources, so they need to be able to pay them. They're not listed, actually, as I see on this sheet as well.
That's a great point. In fact, there's one in the state that is a real model for how to do this within the organization. That's a great idea. And I love talking about that.
To the marketing point that I'm sorry. This is Ken Gardner again at School of Medicine at U of L. To the marketing point that was being made, I agree that I think that there has been a transition over time. At one point, we needed a lot of resources at U of L, UK, that sort of thing, to actually provide support for the physical infrastructure, the equipment, that sort of thing. As we've evolved, we have more equipment in place and we have better systems. And I think the next step now is to actually push this out more into the state and have our resource center people take it, and provide this information where it sounds like a lot of people in the state don't know that this resource exists, and to make that available to those people out in the state. My concern is if the funding model continues, there will be pressure at UK and U of L in particular to go out and recruit for individual University of Louisville, University of Kentucky concerns, as opposed to recruiting for the statewide network. I'm not saying that would happen right away, but I can see where that would be the pressure point if there's no funding from the state, but just from the local institutions. Is that a concern of anybody else's?
Ken, if you won't say it, I will. Yes, that's exactly what's going to happen on October 1. I mean, we're going to have to be really judicious of training center time because we don't get funded. I mean, Kim's got so many hours in the day and so much to do, and he's going to have to be a little more selfish, as are we all. And I think you're exactly right that we can talk about UK and U of L all day, but a lot of the heavy lifting that, I mean, when people in the rural community want to know how to do telehealth, they want to hear it from somebody like Mary, who's actually doing it from their side. They're not an academic medical center. They don't necessarily want to hear it from my perspective, although I know Kim does it every bit as much as I do. Somebody's finding our phone number because we're getting a lot of calls and we go visit a lot of people to help them set up. But, we had folks in Owensboro drive to Moorhead to see what Mary's doing because they're much more like her as a regional medical center with community-based clinics. But no, you're exactly right.
But isn't the net question on that, how is the world worse off if that's the case than we are today? I mean, isn't that the next question?
Adding
Duplication of services, an increase in our silos. It would not be in the best interest of the state overall. It puts us in a competitive mode as opposed to a support mode. Where there's very little resources in a state like Kentucky, to start duplicating efforts would be the death of this. It's really just not the right way to go.
I'm having, again, guys, I'm the dumbest guy in the room, so give me a break for asking dumb questions. But I'm not sure how what we're doing today is keeping that from happening. Anybody, educate me. I don't understand the premise.
Right now, if somebody asks a question, me, Rob, Tim, support people from UK, support people from U of L, support people from Madisonville, we all get together and we help those people collaboratively and try and get them to the services that they need. If the state is no longer giving any resources, there's going to be more pressure to only do that in instances where U of L has specialties that can make money off of it, or from Kentucky side where UK has specialties that can make money from it.
I understand that piece. But how would that avoid having a duplicate point of service out there if we didn't do that? But, Bob, I don't know what I'm talking about. That's why I'm asking for you to give me a break here. I don't understand if UK, U of L both go out there and separately work with a provider and help them stand up a telehealth site. What is wrong with that?
Oh, and I don't think, I think I see what
See, I think I'm missing something.
There's nothing wrong with that. I guess what I'm saying is if Greg Wolverton from Our Care says, well, I want to set up, we have clinics in Paducah area, we want to reach out to Paducah schools, my response on October 1 will be, so what? I mean, that's not going to help me. And up to this point, I think all of us have felt like a rising tide lifts all ships. It doesn't have to benefit UK or U of L or anything specifically. We will all benefit if this happens in Paducah. But, you know, there's no way I can get the car and go to Paducah and help him out because, frankly, all the benefit will arise for them. It won't help him, it won't help Steve, it won't help Mary. I mean, is that? I do not know where you're coming from.
So it's not so much competition between UK and U of L, it's competition between U of L as a provider and this guy in the
One of the issues, and I spoke to one of the physicians that gave a presentation last week, Dr. Weber, who is an expert on opioid prescribing, and he pretty much described the pill mills pretty closely, and how the legal system can ignore the patients sitting out in the parking lot in lawn chairs waiting for the drug mills to open up. So they know where to go after those people. He said if you open up telemedicine, you'll have doctors prescribing in their pajamas from their homes, and you don't have any oversight of what they're doing. It would be worse than the pill mills, because you know where to go after them now, but you won't know where to go after them in the future if there's abusers in the telehealth field. So it's not whether U of L is going to be in competition against UK. It's the oversight that the board has provided, and the resource centers helps implement those guidelines that the board oversees. So it's not a competition, but it's the lack of oversight in the growth of telemedicine in the future. So that's my take on it.
Way to go, Dave, for that restate. Okay.
I mean, what about on the private side now? It's kind of, I mean, they don't come through the telehealth board, right?
They don't have to.
So I guess
Right.
how will this be different? How would it be different?
That's kind of my question.
If there's a value proposition there, a market drive.
I want these things to stay going. Don't think I'm lobbying against it. I'm just asking let's ask ourselves these questions so that we can have the right answers.
How does the private side use this?
Private Medicare, I mean, they don't have to use the board. They don't have to be members. But it's pretty rare that you have providers that are exclusive to one payer or the other. At least that's not what our goals do. They're going to be a provider that uses private Medicaid and Medicare. So Medicaid will be a part of the practice. But certainly you could set something up. I mean, the private is kind of wide open. The reg is very broad, so you can kind of do whatever you want. If you want to create concierge medicine,
And right now, we're not doing quality assurance or performance improvement or monitoring the people that in Medicaid take providers who are providing the service to patients on Medicaid. The board hasn't been functioning in that capacity, correct?
But you look to the payers to do that based on your HEAP scores and other
Right.
things. So there's a little bit of control there than just other places. And more or less a standard of care.
And so the private sector out there, their standard of care is like it would be for their non-telehealth encounters, correct? I mean, they're responsible for the care of their patients.
Correct.
And, okay. Right, right.
Correct. Other thoughts from the group?
If we could, and I don't want to stop discussion on this, but I think we have an absolute action item in front of us, because I know that again, the session is bearing down on us. If we are going to rewrite the legislation specifically to change the layout of the board membership, guys, got any thoughts? I think one comment on the new membership: we don't have a self-insured company.
I think you're a little light on the position side.
Okay. All right.
David, how would you present that? What's your very specific recommendation?
KPCA, for example, we manage about 17% of the Medicaid population. There's a couple of other large IPAs that I think we've got, again, like we did with the EMR, we've got to get some providers.
We've suggested 2 members from the KPCA.
Well, one from KPCA, one from KMA. But I'm not sure that hospitals.
Oh, you're right. I'm sorry.
Hospitals will have 2, but I'm not sure hospitals drive all this. You've got to have the hospitals involved because they have a specialist. But I think what you want to do to really move this forward is get the primary care providers. I've got over 200 clinics across the state. Our care, Kentucky for this.
I'm sorry.
Sure.
I think we're all at the same table that we're concerned about how telehealth is practiced within the state, right? And right now, we have some discrepancies here. We seem to have a law that's looking at Medicaid and the practice of telehealth. But then the private providers, we're not looking at that in the all other payers. So, and I'm asking this out to the board, are we interested in looking at how telehealth period is provided within the state, or are we looking at a narrow what is our charge here? What do we think we need to do?
Well, DOI has their statute, right, which is basically says it can't be telephonic. I mean, like, that's basically their regulation of telehealth.
Yes.
So, so there is a statute for the rest of the world, but it's very open.
Very open.
Right.
You okay with that? You see what I'm saying?
It does seem.
Why do we have a difference?
It seems like either that statute should be more like this, or this should be more like that. It seems strange that they're so different.
Right, that's my point.
Right.
Yeah, so, and I'm just asking, somebody can educate me, and may just go back to the history of all this from the beginning.
How do you get all stakeholders?
All stakeholders, because in my mind, we're looking at telehealth period in the state. So,
Just like we're looking at e-health across the entire state. I agree.
you agree with that? And
Well,
I'm
I guess
interested.
and a lot of the Medicaid pieces of telehealth are actually in their reg. So, it's the reg that says you have to come to the board to get whatever, certified or stamp. So, if this changes, if the reg changes, then that will change the function of the board, which I know Medicaid are looking at their reg. So,
Can everybody online hear the discussion we're having here? And I really, we're interested in your comments.
And, I mean, I think part of the discussion is, yeah, I think they can. I think part of the discussion has been where does the regulation for the actual practice lie? Is it in our board or is it in the licensure boards? And we always,
I think right now it's in the licensure.
it is. And again, we always focus on medicine, but it's nursing and PA and it's everybody's. And I do know that the training centers, we've sat in on extensive sessions working with several of the boards to help them draft their language. But there's probably a lot more we could do. I would love to leave it with the licensure boards.
Well, as a practical matter, it seems like the insurance companies, through their contracts with their providers, I mean, they could do some things there too if they wanted to. I don't know if that goes.
The other analogy is what we went through in this state when we nationally there was a movement to transform the emergency medical services. And before there was any infrastructure in the state took a group of us that were on the state EMS board, and we were the ones out there measuring the width of the cabs and the height and checking the equipment. And that's sort of what the technical centers have done at this point. And you formalize it, you put not just a process in place, but an infrastructure in place that then really pushes it. And that's when you get innovation involved, you get the regulatory effect of everyone safe from harm, and the state's fulfilling its role in the process.
Innovation is happening within the system as it currently is. For instance, here at U of L, we're working with a grant right now with our surgery department where we're using other H323 compliant products. For instance, we're going to use Blue Gene for the most part, which is software based, but it's H323 compliant, HIPAA compliant software where people are going to have actual health care on their iPhones or iPads for follow-up surgical visits. So I think innovation is happening within the network now. It's just happening within a standards base, which makes sure that there's a quality of care from a technical side. For the physicians themselves, I agree with Rob that the licensure board is where that needs to reside. We should focus on getting the communication. I think the licensure board knows the practice of medicine better. So I guess my question is, where are we in the concept of, are these service centers, do we see these as being something that the state will eventually refund, or are we supposed to take it that we just need to develop our own independent business models at all of the various places and move forward?
It's the legislature that needs to fund it. I mean, we don't have any other, they cut our budget too, so we don't have any other money. But if the legislature can fund it, I mean, that's who's referenced in the statute. That we shall, the board shall receive an expense fund appropriated for its use by the General Assembly.
I mean, out of which cabinet does the Medicaid money come?
It has its own budget.
Okay. Has anybody thought about that, since there's huge Medicaid savings in telehealth?
Unfortunately, the Medicaid budget was cut not substantially in this budget.
Right, so that's why I was saying that they would probably want to support telehealth, because without it, it's going to cost them even more money. If they're already short on money, it would seem like maybe they'd want to support these service centers to try and preserve that.
Dr. Langfield brought his personal checkbook.
Well, I think conceptually, and nobody disagrees with that, but I don't, say what's the actual, gets to your point, what's the actual value proposition? We say that, we say, well, we're going to have that cost avoidance. Is there a good value model that somebody's actually quantified that?
Seems like a good function for the board.
Right.
To get, to get the makeup.
Rob, I guess you can speak to this as much as the rest of us that are the resource centers. We see what the other states and what other programs across the country. In actuality, truly, no one has been able to truly put a dollar figure to your cost savings. If all the programs across the entire country have never been able to actually pin down dollar amounts that you can prove what kind of savings you are, maybe a small program here or a small program there, but a statewide network like this, the figures aren't out there. And for the state of Kentucky to make up numbers and to try to prove a fact like that, I don't want to look like we can provide something. I don't think we can provide something like that. Am I wrong, Rob? Tell me if I am, because
look, that is a shortcoming of the entire industry. I mean, we've done a poor job doing that. Right. And frankly, it's, from my perspective, given the, we saw a decent expansion of what you could do with Medicaid in 2013. But prior to that, the regs were very, very restrictive. And, in order to justify the program, and you guys did it too, we went after contracts. I mean, frankly, without correctional contracts, I don't have a program. And you guys have done a great job in contracting with regional comp-care systems, where you kind of bypass some of the challenges that we faced otherwise. But yeah, if I look at my volume of Medicaid versus volume of correctional or industrial health, Medicaid's not doing it. That is a big issue, I'd say. So we don't have the numbers, because we frankly went out and tried to support our programs, and we did it through ways where we could generate revenue. Certainly in my case, that was through corrections and industrial.
So, hey, Rob?
Yes.
What else besides the makeup of the telehealth board membership should be addressed if there is going to be something put forward as new proposed legislation? Is there anything else in that document that needs to be addressed that you can remember off the top of your head?
I don't think we put anything in the document other, really the document is, the original legislation is very broad. So the two things that, we could look at with the change of the board makeup, and then if you wanted to try to hardwire funding. Those are really the only two things I think that we would need to, that we would even consider.
What about something that addresses consumers and patients in terms of engaging them, particularly the ones patients that are high utilization intensive individuals for services, which is where all our costs are, and figure out or put some sort of statement in the legislation that says we're going to look at that and we're going to figure out how to get them engaged via telehealth, which is very broad, very open,
right,
but might entice the private sector to focus on consumers and patients using telehealth to get engaged in their own health care, particularly ones that are remote or don't have easy access to facilities.
So so for policy people in here that know more about this than I, is that something that you put in the legislature, or do you put that into regulatory language? I don't know.
I don't either, but I would have thought it would have been an excellent product description, Bob, for the services we want to sell to these payers. That's where the description of services, I think, would be excellent, and it's a great idea. It's a good cost-saving idea that I think these resource centers can assist with, and it should be something that these payers would be interested in buying the services for.
Okay, so then the options that we have to put into for legislative change would be to change the membership, board membership. We can always ask for an appropriation, but then we ought to ask for at least some consideration for whatever you call it. I typically call it remote patient monitoring, patient forward telehealth that especially oriented to the high utilizers, keep them out of the hospital. We could certainly, I'm not sure there's a group we can narrow that down now, but we're going to have to start on this pretty quickly. We're going to get it in front of the legislature. I mean, guys, are those 3 points? Change the membership, and, see if there's a way to hardwire some appropriation, and then also this kind of patient-oriented remote patient monitoring focused on high utilizers. Is that a framework for what we asked for in the legislation? Okay. Then I'll ask again, with the addition of at least one self-insured company because really big self-insured companies, especially that use telehealth, they are an ACO. They are where we're all going. So let's add, and I think we know one that probably would be happy to join the board and describe their experience. And this is a company that, and telehealth can't take credit for it. Telehealth was a part of the solution. This company, over a period of years, has reduced per member per month healthcare costs. Nobody does it, but they did. And then look at more physician input, physician involvement. Okay.
As the membership in the self-insured community, includes membership in purposes.
Right.
You got to sell them.
Yeah. Okay. Yeah, we have to sell them because we don't have Medicare saying you have to have electronic health record. I mean, that's the advantage EMR's had over us. Nobody mandates telehealth. So right, and they paid them to do it. Yeah. Okay, so guys, we'll work as a group to draft this. We're keeping you guys a long time today for this, and I appreciate it. Anything else before close of business? We will turn around this stuff and get it back to you. We will keep this up on email because we're going to have to get this moving in legislation pretty quickly.
Is there going to be enough for a meeting?
Well, yeah, I mean, there would be one in December, so, and I don't. Oh, it does, thank you. I don't know. December 15th.
And just for the record, I looked up the spring board meeting. The spring meeting at Greenbrier is March the 29th to the 31st. They have those dates in the
Yeah. All right. Okay, guys.
One last statement from here. My big concern is, will we be able to keep the telehealth offices open at the 4 service centers right now long enough to wait for legislative funding. That is a concern.
No.
And this isn't a budget year for the general benefits.
Right.
There wouldn't be any money.
Thank you.
Right, no, fair enough. Fair enough. And guys, and also, just so that you know, that Donna did a remarkable job pulling a front and back page document together of Kentucky's legislative and regulatory policy summary. I proved it, but she did the heavy lifting on this. It's really very comprehensive, so everything is done in Kentucky. Okay, yeah, move to adjourn tonight, everybody. That's enough for today. Thank you all. Yeah.
Rob, I have one more. It doesn't have to be
Yes.
in a minute.
No, go ahead.
As far as the exchange of ideas and thoughts and suggestions and questions that we're intending on doing between now and the next board meeting, instead of just waiting until the next board meeting, is that going to be open, or is that only going to be amongst the board members? Are we, because the board is open to the public, I think.
We'll include everybody. I don't see why we can't include everybody. The board will make the decisions, but we'll include everybody.
Right. Okay, I just getting the clarification. Thank you.
Yeah, absolutely. Okay, guys, thanks for the work today.
Bye, guys.
See y'all.